I am Professor Adarsh Kumar from India, and I am thankful to the organizers for organizing such a nice World Congress on Cardiovascular Diseases. And my topic for the talk in this conference has been multiple vessel coronary artery disease, whether we should go in for percutaneous intervention in such cases or we should go for surgery. The previous trials have been showing almost identical results with the two methodologies of treatment. However, most of the cases in those studies which were taken, they were simple cases with not much involvement of multiple vessels of complexity of left main coronary artery disease, etc. And subsequent trials like Freedom trial, Syntax trial, and other recent studies, Excel studies, they have shown that in case of double vessel disease with the LAD proximal being involved, if we take CABG or PCI, the results are comparable. On the other hand, if we take multiple vessel disease and Syntax score, which has been shown to be very effective for functional assessment of coronary artery disease, if it is high, in that case we should go for bypass surgery. If in multiple vessel disease patient is having Syntax score less than 22, then these cases they can go in for PCI also. On the other hand, as regards left main coronary artery disease, this is more difficult to be treated with the PCI as compared to coronary artery bypass surgery, particularly the distal bifurcating lesions, they are more difficult. However, with the new advancements in techniques like BIOS DS type of stents, like fractional flow reserve and like IVUS studies, and in addition to this selective involvement of kissing balloon technique or double stenting or a stent which is known as BIOS DS stent, where the proximal diameter is different, distal diameter is smaller. In that case, these cases can also be taken up for percutaneous intervention. As per Syntax trial, 1/3 of the cases of left main coronary artery disease, they were found to be favorably responsive to the PCIs as compared to coronary artery bypass surgery. But most important aspect is we must see that there is clinical improvement, there is lesser amount of mortality, there is lesser number of MACE, lesser stroke in all these situations. And this type of thing has been seen in the recent trials, particularly the Freedom trial and the Syntax trial. They have clearly shown that in patients with high risk case, where there is in addition involvement of Syntax score which is very high, and particularly if the patient is diabetic, if there is evidence of any LV dysfunction, in that situation perhaps coronary artery bypass surgery will be a better option. Whereas in lesser I mean serious situations, in such cases we can go in for percutaneous interventions. And the best way for such type of decision making will be to make a heart team in an institution involving a cardiologist as well as a cardiac surgeon, and the two together they will decide whichever patient require PCI or whichever patient is requiring coronary artery bypass surgery. That will be the best approach. In addition, recently it has been seen that fractional flow reserve, it detects the functional involvement of inducible ischemia, and if fractional flow reserve is less than 75, then these patients they are all for coronary PCI should be taken up, and if the fractional flow is more than 80, in that situation these patients they can be left over to medical treatment. A recent FAME study had shown that those patients who had fractional flow reserve based coronary angiogram and PCIs, they had favorable prognosis at 2 years as compared to those who didn't have fractional flow reserve based trials. In addition, there is one ESCAPE trial which is very recent, in which it was shown that those patients who were having angiograms and had fractional flow reserve, those who were left out as compared to those who were put to sub PCI on the basis of fractional flow reserve, it was seen after 5 years those patients who had no PCI, they had better prognosis as compared to those who were put on percutaneous intervention, implying thereby that functional anatomy and functional involvement of the vessels which are anatomically stenosed, that is very important. Whereas on the other hand, coronary artery angiogram, it just detects the anatomical aspects of the coronary artery disease. Therefore, it is very important that we go in future with fractional flow reserve and syntax score as the most important hallmarks in deciding which patients of complex multiple vessel disease or left main coronary artery disease they will require PCI, and which patient will be requiring coronary artery bypass surgery, and which one will be left out for advanced medical treatment. That is what is the most important aspect. Lastly, the concept of total revascularization is also now coming to being challenged. It is said that rather than going for total revascularization, incomplete revascularization involving PCI of the ischemia based territory and medical treatment of the non ischemia based coronary artery disease, when combined together, perhaps the results are comparable to the total revascularization. But the best decision in this regard will be dependent on the treating cardiologist as compared to what it is as such on the medical grounds. So, I think this is sufficient.